Hi, everyone. My name is Alex Castillo-Smith, and I work with Secretary David Scrase at the New Mexico Human Services Department. Thank you for joining us for this COVID-19 Day 129 in New Mexico press update. We've got a number of topics for Secretary Scrase to cover today. I think, David, I'll just outline sort of the structure, the flow of the conversation, and you can let me know if that sounds good to you, and then we'll get started with your remarks. How about that?
Great.
Okay, and so we've got a number of topics to cover, some stories that have been in the news or in the media, some emerging science. David will go over a New Mexico COVID-19 update, and then we've got a wealth of age-related data for COVID-19 in New Mexico that David will share. And I will, if folks have questions pertinent to each section, you can raise your hand using the GoToWebinar function. You can submit them in the chat or the questions function. I'll interrupt David so that you all can ask questions related to each section. If you'd rather wait until the end of his presentation, we can take questions after the end of his presentation. And to the extent that I'm able and that you all are able to participate, you will be able to ask your questions to him yourself, unless otherwise technology prevents that. So the final thing I'll just say is that the link to this webinar recording, as well as the presentation that David's going to share today, will be shared with all of those who registered for today's webinar. I think that's it, David.
Great. Thank you very much for everyone for being here. I apologize. It's my fault. We're starting 4 minutes late. I was testifying before the Legislative Finance Committee for 3 hours and 4 minutes, which was the extra 4 minutes. And I'd remarked, it's been a busy week in state government. I'd remarked when we started at 8:30, that was my number six meeting of the day. This is number 7, although that doesn't seem as extraordinary now that it's 11:30. I picked a few topics in science that I know of are of interest to all of you, either because you've contacted us or there have been prominent in the news. And the caveat on all of these is I'm not an expert in any of these fields, but I'm just trying to pull together and coordinate information. So I thought we'd start with just a little bit on the science side about immunity and vaccines. And so there's good news and there's bad news and there's confusing news about vaccines. This study from the United Kingdom in King's College found that 60% of people developed a pretty potent antibody response when they had COVID, but 12 weeks later, 3 months later, only 17% had antibodies. And so there's a rapid drop off in antibodies. And so, we don't know yet, because there's different kinds of immunity, and I'm not an immunologist, different kinds of immunity, but certainly the kind of immunity, the antigen antibody immunity that we rely on for many of our vaccines. This is not good news for the folks working on a antibody type vaccine to the COVID virus. There's good news though, so don't give up. On the other hand, there's other kinds of immunity. There's a T-cell immunity that's different than just an antibody function. And that there's some early research that shows that there's a strong T-cell immunity response that lasts a lot longer. And it looks like it turns out that exposed healthy people who we don't know to have had the disease may also be developing these antibodies. So that's some good news as well. So, I said antibodies and that was incorrect. This memory T-cell immune response. And so we've got, for those people working on those kind of vaccines, this is very good news. Also, one of the things we're going to talk about a lot today is asymptomatic individuals. We're learning a lot of that, a lot of information about them. People without symptoms don't develop the same level of antibodies as people who are symptomatic. And you can see that your chance, seronegative means you go back to not having any record in your immune system of having COVID. Happens 40% of the time. in asymptomatic people and 13% of time in those who are symptomatic. So it means that what this means to me is that, and again, this is back to the antibody type of immunity, not the T cell immunity. What this means is that these asymptomatic infections that we are hoping will help us with herd immunity might not be as helpful as we were hoping they would be. Vaccine development, there are 155 vaccines developed in development, 23 in human trial phases. And the first vaccine tested in the US, I agree with Dr. Fauci that did significantly stimulate the immune system, and that really is good news. On the other hand, we don't have any existing vaccines for an RNA virus. Influenza is a DNA virus, and AIDS, HIV, which we've been looking for a vaccine for a very long time, we've not been successful. So, and also remember that just developing this vaccine is the beginning of a very, very long process to get people fully immunized, and there will be lots of hurdles as we go. But it does appear that a lot of people are working on this. There's a lot of science going into this. I sincerely hope that several of these 155 vaccines will turn out to produce lasting immunity. And by lasting, I'm good with a year. We get flu shots every year because the vaccine for flu doesn't really provide immunity much past, 6 to 9 months. So every year in the fall, most of us get a vaccine for the flu that carries us through the next year. In addition, it boosts the types of flu that are in the vaccine this year that were in it last year. It also creates immunity for the new types of flu that are in the vaccine almost every year as well. So I'm feeling good that the world is addressing this. There's lots of different kinds of vaccines, and I'm not going to go through all of them today, just because this is more, I think, a little bit more too much science, but this is where we're at. And so lots of categories, lots in clinical evaluation, and something that we can be happy about, I believe, going forward. I'm going to switch over to masks now, and we'll get through all these slides and we'll stop, but we can go back to anything, and I'm happy to pull slides or go back to slides if you have questions about the slides. As you know, I'm on a kick to every single time talk to people about wearing masks, remind them that it should cover both their nose and their mouth, and preferably their chin. Anchor it. You can see several examples. I demonstrated those. That was my 15 minutes of fame, was demonstrating how not to wear a mask. And I heard something that I thought was interesting this week. And this is really more a message to people who don't wear masks, but just to call everyone's attention to the fact that in operating rooms in America for the past 100 years, everyone has worn masks. And it's not that operating rooms listen to too much NPR. They started doing this before NPR. This is really there's science behind this. And for those of you who are your readers who still struggle with this concept of wearing a mask, I have a question, and that is, if you had to have an upcoming surgery, how comfortable would you feel with your operating team not wearing masks or not wearing gloves? And I think I haven't run into anybody yet who would feel comfortable with that kind of scenario. And so what we're asking people to do when we're asking them to wear a mask every single time they go out of the house, no matter what they're doing, unless it's eating, drinking, or swimming, we're just asking them to take the same exact precautions for the fellow New Mexicans that our Department of Health asks every surgeon in every operating room to take each time someone undergoes surgery. So I like that analogy. I think it cuts to the science of it and why we do it and the importance of wearing masks. I did want to, I get a lot of emails, and we do not promote these masks with valves, and particularly if it's a one-way valve where it exhales. There's some masks where you can breathe out with the mask. They have exhalation valves. Obviously, those don't prevent the spread of COVID. You are not if you have COVID and you're breathing out through that mask, that's spreading the virus. Because it's a one-way valve, it might protect you, but we're not recommending those. And a number of people have asked me to let you all know and ask you to tell your readers that the masks with valves are not recommended. You know, cloth coverings and bandanas aren't ideal either, but they're way better than nothing. We don't have hospital workers wear cloth masks or bandanas. They wear a procedure mask. My wife actually wears a procedure mask at work, then leaves work, takes off that mask, puts on her cloth mask, goes to her car, and comes home. But they do work in non-medical settings and substantially lower transmission. We know that, and so just another commercial in the many commercials. And I love this study. I think it was reported in the news a month ago or two, but then the CDC officially reported it in their morbidity and mortality weekly report with more detail. But there were 2 symptomatic hairstylists with COVID, and they wear face masks. They took care of 139 clients. I'm pretty sure they didn't know they had COVID while they were still had their salon open. And they were able to track down 67 of the clients who they did treat. They did provide styling services for. None of them were positive. And it's kind of a remarkable report from the CDC because it makes the point that, you know, masks are actually quite effective because that, when I always talk about how long is the contact, well, it's longer with a stylist. How close is the contact? It's very, very close. And then how many people are present? Well, that one's a little lower. That's you and your stylist. But I think a lot of epidemiologists across the country are saying this is a remarkable anecdote. It's not really data, but it's a remarkable anecdote about the effectiveness of masks in preventing the spread and transmission of COVID. One last topic and some research on this. We've brought this up, you know, often without as much data, but we really are beginning to see the uptick in what we call deaths of despair. New Mexico already has one of the poorest records in the country. Deaths of despair include a drug overdose, a death from alcohol, and death, of course, when someone takes their own life. And they trail the cases by a month or two. I'm not sure we completely understand that, but obviously isolation is a key factor when people are socially distancing or staying at home. And there's a lot of uncertainty, which for folks who already suffered from depression or anxiety only makes that a lot worse. Social isolation plus unemployment are associated with increased rates of suicide. We do know that. And we also see in countries that provide some sort of income support for people who become unemployed, the more they provide it, the lower the suicide rates are. Not my favorite map. The darker, the worse. And we can see a very clear black outline here of New Mexico. And I'm not exactly sure why they projected over the next 10 years for this, but this is already a risk for New Mexico. And with COVID, it's an even greater risk. You can see that our rate in the population is not quite double for deaths, but unemployment, which does correlate, and additional deaths, you can see that more than double additional deaths here per 100,000 related that we think have been related in the past to unemployment. So of significant concern, our unemployment rates went way up. They're on their way back down, but still something we need to watch carefully. One more, I think, one more is on pooling. I've gotten some questions about that from folks this week. What is pooled testing and how does it work? And I'm just gonna give you the example and then you can carry it on from there. Let's just say a company has 100 employees and they're in a place that has a 5% positive COVID prevalence rate. That would be very, very high. There are very few places that are that high, but that would be high. New Mexico as a whole is still less than 1%. And so what the employer, it says the employer splits them up, but it's really the lab that does this. Well, you sample all 100, but the samples go to the lab in groups of 5, okay? And so these are just all the people segregated into 20 groups of 5. And then here are the positive ones, so these black dots. And so that you mix together the nasal secretions in the lab. That can be done in an automated way to prevent worker repetitive motion injuries. And then you test all these lots, these combinations. And what you're going to get is 5 positive tests. So you tested 20, you got 5 positives and 15 negatives, the rest of them. So you take those 15 off the table, and all 60 of those people are negative, right? You combine all the tests, those were negative, so no one can be negative. In this group, these 5 tests should turn positive, and then you go back and retest each of the 5 samples. So you've done only 20 additional tests, or in theory, you could do 4 additional samples, and if you didn't get a positive, assume the last one was, but we don't do that to people, so we test all 5, that's another 20 tests. So you've done, a total of 45 tests, the initial 20, and then the 25 individual in these 5 cells. And so that saves reagent, it can save labs time. It is, in order to keep up with the testing strategy we've outlined, it's something we're gonna have to do. So the medical advisory team is working on that with representatives of the Department of Health and from the private sector lab community and the DOH lab. And Tricor is currently doing pooled testing studies that we believe will be the data will be available later this month. The DOH lab testing getting underway should be available sometime in August. And so remember though that even if we can prove to ourselves that it works, you can't do it without getting FDA approval. So there's a lot of steps ahead of us, but we think that we're hoping the manufacturers of these machines actually beat us and get what's called the EUA to use their equipment for a purpose other than for what it was designed. And so I think you'll be hearing more about that in the next probably month, but it is a strategy, an effective strategy to extend testing. It can be cumbersome, and we're only really interested in doing it if the machine can automate the pooling rather than having lab technicians who are in scarce supply, given the volume of what they're doing this pipetting of each sample each time. So those are the science questions, and I think I'll just keep running through.
That's fine, Dave. We've got no questions yet.
Okay, good. So, okay, test results, tests up to 443,000. I'm pretty sure that's a little bit over, I know it's over 20% of our population here in New Mexico has been tested now. Again, amazing work by Secretary Kunkel and our private sector partners. We're really doing a lot of work testing throughout the whole state. Hospitals in particular have taken a prominent and valuable lead role that's clearly helping us meet goals like this. And then cases, we don't have the case counts yet for today, but up to 116, over 16,000. I remember when we talked about this early on, people could not comprehend that we could have 16,000 cases in New Mexico, but of course we do. And I should redo the math on that. 160. No, we're still below 1% of our population, I believe. I was on the Legislative Finance Committee, and George Munoz today asked me, we understand you've got these gating criteria, and we understand we can go to the website, we understand everything and all that, but I just want one thing to look at to let me know how we're doing and to let me figure out, and my wife figure out about our kids going back to school. And, is there one thing you could suggest that would be the best measure? And so, I answered, well, I don't really pay as much attention to the daily case counts, but I do look at the 7-day rolling average. That's my go-to metric for how New Mexico is doing. And of course, looking at this metric, we're doing poorly. We were about 100 here at this point, and now we're up to a rolling average of 270 cases a day. And so not good. On the other hand, we're doing great with testing. So Alex, I told the Senate Finance Committee that or the Legislative Finance Committee, that we would get this somewhere more prominently on the website, and you and I can talk about how to do that. But this is the what I look at, and you know, obviously, this significant upward trend is not what we want to see. You'll see more of a graph of that. I don't know if Colleen Hield is on the line today, but Colleen, you were asking about why are cases going down, you know, cases going up here and hospitalizations going down. And well, even if you're not on the line, what I told her is, wait, get back to me in 2 weeks, because we fully expect to see hospitalizations go back up. Now, interestingly though, one, they did go back up in 2 weeks, as we expected, because as you have more cases, and there's about a 13 to 14 day lag between, and I actually measured this where it started to uptick to, I think here where it started to uptick, and it's about 13 or 14 days. So you can see that we're getting that uptick now, but we don't seem to have the same kind of number of admissions as I think I was expecting just looking at the raw numbers of yes, and this data is incomplete, this 213. It was different than the rolling average on the previous slide, so you probably shouldn't even be showing that, because lab tests come in, as you all know, sometimes 4, 5, 6, 7 days later. But that's that lag. So first it's cases, then it's hospitalizations. This time there's more of a lag than there was at the beginning, but it is about that 2 week period. Did I go backwards? No. So tests, rolling average, positivity rate. I know we're getting more questions about that. It's in the news more. You know, we want to be below 5%. If our test positivity rate is above 5%, it means we're probably not doing enough testing and not finding enough asymptomatic people. So 3.91, I think, places maybe not the best in the country, but probably in the top 5 states in terms of our positivity rate right now, which is great. Our positive cases yesterday are here. The total positive cases in Bernalillo by early next week, if things keep up the way they are, or late next week, will surpass McKinley County as the county with the most number of cases. Almost a vertical line uptick in Bernalillo County in cases. And you can see that from the data just in the past 7 days or 6 days that Bernalillo has added 653 cases to McKinley and San Juan's around 150, and even added together, they don't get to half of the Bernalillo cases. And a big surge in Doña Ana as well. Lee County, I think 24 cases or something like that yesterday, but big uptick there in southeastern New Mexico. We know there, Curry as well, lots of back and forth travel to Texas, and lots of people who work in New Mexico who live in Texas. And some of that we can't stop. We can't close our borders, but it's impressive that we're seeing this uptick. And I think it's probably something we're going to see for the rest of the pandemic. Any characteristics of people getting together with other people, or commerce, or anything else will produce an inevitable increase in cases.
Hey, David, we've got a couple questions.
Sure, let's pause and do those.
Yeah, so I'm gonna unmute Julia Goldberg so she can ask her question.
Julia's gonna, we'll unmute Julia so she can ask me yet another question we do not know the answer to. Go ahead, Julia. You're on mute. Let's give Julia a minute to figure out her audio.
Can you hear me now?
Yes, I can.
Okay, thank you, Dr. Scrase. When you were going over the positive test rates, I have a little bit of a hard time reading that chart. New York earlier in the week put New Mexico on its quarantine rate, and their criteria is any state with a positive test rate higher than 10 per 100,000 residents over that 7-day rolling average, or a state with a 10% or higher positivity rate, also over a 7-day rolling average. I don't see us meeting that criteria, but I don't trust myself to know if I'm reading that correctly.
Yeah, well, Julia, I will confess that I did not already have plans to go to New York or Connecticut or New Jersey, but I did look it up because I was indignant that we were now excluded from other places. And I read that as sort of a not an and criteria, but an or criteria, that if we met any one of them. And so
Okay.
my take was on it was this cases per day rate of increase from, I hate to go all the way back to when we had 100 up to 270, but I think that's what tripped our the New Mexico wire in their new, if you will, immigration system that lets or doesn't let people into their. I think it's only by air travel, right? They're not. Are they?
It's just
stopping?
it's just air travel. You have to fill out a form,
Yeah.
and if you don't fill out a form, you have to pay a fine. So that what you're showing, that increase does constitute that
Yeah.
that test rate. Okay, all right, that makes more sense. Thank you.
Yeah, we've been running a daily case rate increase of 1.8%. So you multiply by that by 7, you're over a 10% per week increase, et cetera. So is there another question, Alex?
No, David, there's one about death data, but you're going to show some data related to death and age shortly, and I figured go ahead.
All right, let's just go on then. We'll show you that. You've all seen this. Very bad news. And I think the thing that keeps me up at night, but more so our epidemiologists, is not this curve. But unlike in the past where we could find one curve that, like, this peak is, Bernalillo or central New Mexico, this peak is northwest. This was just a big spike in Otero correctional facilities. That's over. And now this giant, bigger than the others. I mean, even look at even from here to here versus here to here, that uptick is going to be bigger. It's contributed to by virtually every region. And that's what's bothering our epidemiologists, is all of these are, at least to some degree, trending up. So COVID is everywhere. It's everywhere people are. It's all across the state. It's not just in one of our regions anymore. Hospitalizations and intubations. This is another version of what I showed earlier when I mentioned Colleen Heald, but we see this uptick we're getting now in hospitalizations. But we have some really, really good news, and that is a lot less people on ventilators. And there's a variety of theories. One is that we're using different ways to treat people to try to avoid getting them on ventilators. There's a theory that the remdesivir that we're using for people to try to keep them off the ventilators may be working. We're having great success in New Mexico with taking up and use of remdesivir. We don't have data from our own state about what we think that's doing, and I don't know if we will actually. I'm sure there's some studies going on. But this fact that, there was one point here, I can't remember where it was, but maybe right around here, where for almost 40% of people in the hospital were intubated, and now it's down to about 20%. I mean, you can do the math. No, I guess it's not that low today. It's more like a quarter, but yeah, it's about a quarter or so, maybe. But nonetheless, good news there. And the reason that's good news, we'll get to it a little bit more too, is it could be that as more people, younger people get cases and get hospitalized, while we have seen some really serious issues in people under 30, at the same time, the early indication is that not so many of them are ending up in ICU. So I don't have enough data to say that we know that, but we are now tracking that also. Growth rate, I just mentioned in answer to Julia Goldberg's question. You can see we're up to 1.8%, highest growth rate since June. We could go back. Of course, it was even higher at the very, very beginning of the pandemic, but this is a fairly high growth rate. And here you see it broken down by the various regions of the state, and you can see that, and I wish that the Southeast is sticking out like a sore thumb. They had growth rates up. They had a growth rate in Lee County on Tuesday, I think, of 6.9%. And that's a day. So if you have 10 cases, the next day you have 16, then you have 26 times 1.06, et cetera. So really fast growth in that part of the state. We're watching closely. And then of course, Central Metro, driven way up by the growth in Bernalillo County.
Hey, David, we got a question from Nancy Laughlin. So I'm gonna take a moment to unmute her so that she can ask her question. Okay, Nancy.
Hi, Dr. Scrase. Can you hear me?
Hi there.
Hi there. My question is about when and if do you think kids will be able to go back into the classroom physically?
So let me say that that's a question that doesn't necessarily relate directly to this data, but this is not a good sign. I've been working really hard to address return to school issues with the MAT, with the modeling team, with the Los Alamos National Lab. The governor herself has suggested an alternative scenario to be analyzed. But right now we're looking at basically four options. Option one is everyone stays home and learns remotely. Obviously, huge disadvantages to that because kids really do need to get back to school. And generally, the spread between kids is not our problem in the state. However, teachers get COVID, and as we send kids back to school, parents become more mobile, and case rates have gone up almost everywhere. I've spoken several times about the study out of that looked at, and I have the countries right now, Norway, Denmark, and Germany, where Norway and Denmark opened their schools very successfully with low ambient case rates, and Germany opened with higher ambient case rates. They were in a similar situation to us right now, with not as good results and rapid case growth. The other thing on that topic with teachers is teachers, because really when you reopen schools, you don't see a big increase in cases in kids, at least in the countries that are studying this. But what you see is a lot of teachers getting infected. And so that threatens the viability of a continuing school as well. The four scenarios are all distance learning, a hybrid model where people are there, half the kids are there half the time and telelearning the other, and vice versa. The other kids then come in and are there half the time. The governor's one she asked us to look at was closing high schools completely, having that all be telelearning, and then using that high school space to spread out some of the elementary and middle school classes. It turns out that, and then there's just sending everybody back to school 5 days a week, but with very rigorous social distancing, masking, PPE, looking at perhaps eye protection, looking at air and ventilation systems. And so we don't have the final data yet. It looks like that the hybrid model I described is a little bit better, a little bit safer, generates less cases than the closing the high school model does. That would be all students, all grades, half time there, half time away. So I think the intention, I know I've had not a meeting every day, but most days this week. I've got one this afternoon. I think our intention is to get the data wrapped up, the analysis final, and present something to the governor next week sometime.
Okay, thank you.
That's the discussion that's going on. And a lot of the questions I got at Legislative Finance Committee today were also about school reopening. So we know it's the #1 issue on the public's mind. And we know that I'm not really sure how other places have gotten to just like keeping school closed for the fall altogether. I'm not sure how they made those decisions or what data they had to use, but the modeling that's being done by the Los Alamos National Lab is pretty complex. Some of the programs take hours to run to generate how that would work out in all areas of the state. And so I think great work being done there. I would say off the top of my head, and I might go back later and change my answer, but this might be the most data-based, science-informed decision affecting over 250,000 people I've ever had the opportunity to participate in. I mean, it's what the information we're getting and the detailed considerations are pretty phenomenal, including things like the fact that high school students will building in a % of interaction they're going to still have with their peers, whether we tell them to or not, and things like that. So it's really some great work that the MAT is doing on this, that I'm personally very proud of. And I think independent of what everybody's political and emotional responses to the answer, I think at least we will have done everything we possibly could to look at those scenarios carefully and ensure safety of everyone in New Mexico. So probably longer than the answer than you're looking for. So the answer to your question is, are kids going back? The answer is, I have no idea. But we are concerned about the background noise here in New Mexico right now, and hoping that we see folks sort of turn this corner, see cases level out. Thought that was happening, then we had 300 yesterday or the day before, and so we need to see this level out at least. So that's the answer.
Thank you.
You're welcome. I already did this one. I'm going to skip this one if you want to look at it. It'll just tell you the number of cases by region. This is Johns Hopkins data extracted and used at a different website. The link is at the bottom. And you can see that we went up like everybody. We plateaued off lower than many states. We stayed plateaued for a really long period of time while a lot of other states crossed our curve and came back down. Not a lot, but some. And now we're gradually trending up again. And this is a logarithmic scale, so if you're not used to looking at those, it goes from 10 to 50 to 100 to 1,000. So it is important continued uptick in cases. Travel may be good news. We believe that the best correlate to daily case counts is movement of New Mexicans around the state. And that makes sense because the more people contact each other, the more they are likely to spread the virus. If everyone were driving their car, 9 miles and staying in it by themselves and just looking at a beautiful sunset from a better view than their backyard, then we wouldn't have spread. But on average, this is our tracking, and high, down, gradual up. And when I squint at this, other than the Southeast, where we're having big problems right now, I get the sense that there's a leveling off of the other 4 regions. This one did go down and come back up, so we'll watch. But this should track what we're seeing with case counts, and the more people travel, the more likely, the higher the case counts will go. And that's been true through most of the pandemic. There's always that 2 to 3 week lag, but that's been true. And this is just all of New Mexico pulled out, so it's a little easier to see. But I really believe we've seen a little bit of leveling in mobility the past 3.5 weeks. And I would be remiss if I did not give the press credit for that, because I think the job you're doing, getting the word out and informing people, is really, I think, what goes into them making decisions. So that's why we take the amount of time we do with folks from the media, and is because it's, I wish I could remember which reporter it was, and if it was you, let me know. But after the very first press conference, a reporter pulled me aside as I was leaving the room and said, "Dr. Scrase, what do you think the biggest problem you're going to face in the pandemic is going to be?" And I was, I knew he was, thinking, is it PPE? Is it ventilators? What is it going to be? But my answer was communication. And he looked puzzled and said, "Communication? Why that?" And I said, "Well, that's always the biggest problem in any big emergency." And so I just can't tell you how appreciative we all are of the work you're doing to cover this, whether it's good or bad, favorable or not favorable, delivering information to people so they can be informed and understand the personal consequences of the decisions they make related to COVID is a really important tool that we have as all of New Mexico to make this work. So thank you so much for that. I'm going to just let you peruse this at your own, but G. Wang, our crack data analyst who PhD actually is behind, I think, all of this stuff, the graphs you see most days, has done this thing with all the public policy orders, and red ones are orders that tended to decrease mobility, and green ones are ones that increased it. And you can kind of judge for yourself whether upticks are followed by greens or not. I mean, we'd already seen some uptick here, and whether downticks are followed by red or not, keeping in mind that you always have this divot for Saturday and Sunday every week. Okay, so we have some new data, and this is actually also kudos to all of you. Sometimes many of you, not just Julia Goldberg, but perhaps particularly Julia, ask me questions where I don't know the answer, which I love, particularly when I feel like they're relevant, which they almost always are. And so here's some data about the number of cases per week in different age groups, and this sort of confirms what we've seen over the past few weeks, gray being 20 to 29, orange being 30 to 39, and then blue being 40 to 49. So this big surge of cases is not completely, but in large part contributed to by the younger folks. And if you look at this graph, you either will love this or hate this, but let's just take this gray area here. This gray area is the percent of cases attributable to people 20 to 29. I kind of like these graphs because I can squint in them and I can see clearly the proportion of 20 to 29-year-olds is going up. You also can see over time, with the exception of this week, children 0 to 17, and other young adults 18 to 20. I get coached on this a lot because we have folks who are sensitive about not calling 19 and 20-year-olds and 18-year-olds kids. But you can get the sense that that number is drifting up as we've been reporting. And it looks like it's in the 15% range now, which was higher than it was last week. Older cases staying pretty steady. Very old people way up at the top here. Actually, less cases lately. We've had some deaths, but I think most of this is very old people over 80 know they shouldn't go anywhere and they're staying home. Thank you for staying at home. These are a little busy and they look like spaghetti, and I apologize for that. If you want to take extra time, hospitalizations again here, and a different pattern. We're not seeing that big jump. Let's find the gray line, 20 to 29. Well, there is, actually, I apologize. There's a jump. It's not as big a proportion, but there is a jump as more cases. And we're also seeing it, I guess, in the 30 to 39, so jump there. But still the biggest proportion of hospitalizations coming in folks over 50, really. And those are all the top 4 groups with the highest percentages or highest numbers of hospitalizations up here.
Hey, David, we got a question from Joy Wang. She asked, how many out-of-state folks are being treated in New Mexico in the hospital?
Yeah, we got asked that at the Legislative Finance Committee. It is not a big number, and I don't know the answer at all, but I do review at one of those 5 meetings I had before 8:30 today, the daily transfers in and out of state and within the state as well. And so it's fairly rare that we actually transport people into New Mexico, but we do. And so earlier this week, I think I noticed and asked about it because I hadn't seen it in a while, a couple cases that came from Arizona. My belief is, it's just a belief, that actually more New Mexicans are in Texas and Arizona hospitals than we have Arizonans and Texans in New Mexico hospitals. I'm pretty sure that's true. We're looking at that now. It's an important question though, because we don't count cases. If we have Texans and Arizonans in our hospitals, we don't count them in the case counts. We just send those over to Arizona and Texas, and they follow those people. But we do include them in the hospitalization counts. And you might think that's confusing and counterintuitive, and I think it is. But the reason we do it is the reason we count COVID patients in the hospital is we want to fully assess our hospital capacity. And we have to count everybody in a hospital bed to do that. We're not seeing a surge of beds in Arizona and folks from Arizona and Texas coming to New Mexico. And in fact, I don't have these graphs. I probably could bring them up, but we do every single morning also look at, in addition to transfers, how many available ICU, regular beds, and surge beds are available in Arizona and Texas both. And they still have large, large numbers, hundreds of beds, and these are in the regions that border New Mexico. So we think we're good there for now. And I'm assuming that was part of what was underlying your question was, hey, I don't want to have to share a ventilator. Well, I'm not going to put this on you, but I don't want to share a ventilator with somebody else in New Mexico if there's 30 Arizonans on ventilators here in New Mexico, and that's not the case. Does that cover it?
That does, David. Those bed slides are at the end of the presentation for your reference from
Okay.
Texas and Arizona.
All right. Thanks. We've been on a whirlwind schedule here, so I don't want to say that I haven't reviewed these slides in detail before this briefing today, but some of them I am actually seeing for the first time, but I'm familiar with the concepts. We asked for these again based on some of the questions you gave us and some of the things you asked. So more on age. This is deaths by age group. And you can see that over 80 age group, we all remember that by week, how terrible that was. And now a little uptick in deaths in what I think, and Alex, just jump in and correct me, but what I think is the 70 to 79 age group. We're not expecting a big spike in that, but it's nice, even though there's still a 2-week lag often between hospitalizations and deaths, we don't think we're seeing a big uptick there, but you can see that the green line corresponds to the green here and a broadening of that wedge for the 70 to 79 age group. Still no deaths in folks under 20, so they're not on this curve, thank goodness. But between blue and this rust color, we've had a steady number of people under 40, steady percentage of overall deaths in New Mexico, which of course represents a very, very large number of productive life years lost, and we really hate to see that.
Hey, David,
yeah.
Before we go on, we have a question from Matt Grubb, so I'm going to unmute him now.
Hey, Matt,
you should be. Go ahead.
Hey there, thanks. This is sort of going back to follow up from what Joy had asked about. Say what you will about Florida, but one of the things that they're reporting is the number of non-residents who test positive there. Obviously, with their tourism industry, that's a big deal. Are you tracking that, and is that reported anywhere?
Are you asking if we're tracking the number of New Mexico residents who test positive in states like Florida and all U.S. states?
The opposite, the number of people from elsewhere who are testing positive here.
Yes, we do. And we refer every one of them to their home public health department. I was on a call yesterday with the folks down south, among others, to talk about our testing strategy. And they report in Las Cruces that people, as many as 100 people a day, are being sent from Texas to be tested in New Mexico. And so that, unlike hospitalizations, I would predict that New Mexico is a net importer of out-of-state testing, just based on what we know about Las Cruces. And I mean, the fact is that other states have not reacted as quickly to the pandemic. Other states may not have governors who are willing to be as incredibly assertive as our governor is to go out and get testing supplies and laboratory materials, and call the White House and call HHS and call the laboratories that produce the reagents. I mean, she's all over it. And so it would make sense, like almost any economic good, where people would actually travel a greater distance to obtain something that they couldn't obtain, at home. And so I do think some of that is happening, Matt. I think we have a little bit of data. I haven't seen a spreadsheet, which is my definition of data. And I do believe that the plural of anecdote is not data, but people wouldn't, even if they were exaggerating, the 100 people a day testing out of 600 in Las Cruces. I mean, it's still a real number, and it's definitely double digits.
Sure. I guess what I'm asking is, like, for example, in northern New Mexico, which is dependent on tourism, does the department have data that shows how many people from out of state are testing positive here? And is there a way, I guess, through contact tracing to figure out how many people are testing positive who have traveled here?
Alex, let's grab that question. I think the answer is no. A similar question came up in the Legislative Finance Committee today. It's a good question, though. And so what you're really saying is, have you guys put together a heat map of out-of-state positive tests? And I think that's what you're asking for. And I'm going to find out if that's something we have the capability of doing, Matt. And if we do, we'll see it. Just like this data you had all these questions about deaths and tests and cases by age group, and you're seeing them now. If we're able to do that, we'll do it.
Great, thanks.
I could guess though that one of the challenges there is, if you're from Texas, you get a test, you give all your home address information, your cell number, and depending on when we get the result, we call you and say you're positive. We might not have in the lab data, which is where you need it, the information. Now, we would capture that in the case interview. We would capture that the person had been in New Mexico and where they'd been in New Mexico. I just don't know if that's information is coded in a database that you could sort and add and multiply. And I'll ask Dr. Smeltzer about that.
You can continue, David.
Okay, I think I'm done here. I think I've mentioned this earlier, but the percent of deaths in people over 80, you remember 3 months ago was where this was our view of COVID. It's mainly going through and, attacking people in nursing homes. That is really changing a lot. I mean, this is 20% and this is 50%. So that's a significant reduction. And yes, a little bit of expansion in the 70 to 80 group, but some more growth in some of these other groups that we'll be watching now, thanks to enterprising reporters who asked those questions. Tests performed per week. Here's something interesting as well. We're seeing a little bit of increase in testing in the 20 to 29 age group. I don't know if that's due to your reporting or the press conferences or greater awareness. Probably it has more to do with social media and people texting each other or on various applications. There was a question that came up that I want to address here, unless someone wants to ask it for me, it's like, hey, look, testing is going up for this younger group and cases are going way up. How do we know that the increase in cases we see every week isn't just due to the fact that we're doing more testing? Because we are, you add up all these curves, I mean, we are doing more testing, right? And so the answer to that, I put that to Paul Fenimore, again, one of our great partners at Los Alamos National Labs, and he did an analysis that I think he'll present to our modeling team this week that I don't, I can't say I fully understand. So the advanced copy on it is that in their calculations, for every 100% increase in the amount of testing or doubling of the amount of testing you do, you see about a 13% increase in cases. And I think some people have held out there, well, we're seeing twice as many cases because we're doing twice as many tests. And if you have a high test positivity rate, where you don't have test capacity for your citizens, that is more likely to be true. But once you get below that 5% mark, where we've stayed fairly nicely for most of the pandemic, then when you're going out and doing more testing, the theory is that the symptomatic people who are sick, well, everyone in the hospital is getting tested. And the people who are going to their doctors feeling really sick, or the emergency rooms, they're getting tested. And people with serious symptoms are still driving to the Balloon Fiesta Fairgrounds or elsewhere to get tested. But when you expand testing further, you're making it more available to people who would otherwise be less motivated to get the tests. And so that's my take on the 87% difference between increasing cases by 100% and, increasing testing by 100%, but only increasing the number of new cases by 13%. So I hope that makes sense to people, but it's a common question, and I might have an even better answer next week. Or we'll put, Alex, let's just make a note to put a slide on that, on the final answer of that next week in our
David,
press
we've got a question from Dan McKay. I'm going to unmute him so he can ask his question.
Hey, Dan. How are you?
Hi, Secretary. Can you address the large increase, the growth in cases in Bernalillo County? Do you have any sense why it is growing so rapidly? And anything else you want to say about the Bernalillo County situation?
Yeah, do we have a slide in here on Bernalillo County, Alex?
I think so, David. Yes, I think it may be after this slide. I can confirm.
Dan, I think it's very, very similar to what we're seeing everywhere else, but let me see. No, this is not Bernco, but I think we're seeing a very significant increase in mobility that is now leveled off. We're seeing more cases in 20 to 30-year-olds and 30 to 40-year-olds than we have before. And in particular, Bernalillo County is quite steep. And so we try not to share county data because in smaller counties, it's actually more likely to be misleading than helpful, but there isn't any reason why we can't share. So stay with me, but it's the same old stuff. People getting together and, it's people being in larger groups of people. We just got off of the 4th of July weekend 2 weeks ago. This would be the time we'd be seeing a big uptick in cases from that. Reportedly, a lot of anecdotal descriptions of large social gatherings and the like. So I think it's people getting tired of COVID and not really believing they're going to get it and sort of feeling like they're in a Southwest commercial where they're now free to roam about the country and not being as cautious, taking the same precautions. We don't have data on mask use, but I think there is an opportunity there to reduce that very steep upward trend by if everyone were to wear masks there.
It's slide 35, David, if you want to.
Oh yeah, let me go ahead, Dan, and one more, okay. So yeah, this is Bernalillo County. So we do have it, and watch this gray area here. It's always kind of variably big, but it looks like it generally almost always encompasses 20% of the cases there. But then you get into the last end of June, early July, where that range seemingly explodes to over a third this week, probably just about a third this week, and now back to about a quarter of cases. So we think this is a driver in Bernalillo County. And let's see, and then we've got some data on McKinley County as well. And, not too dissimilar data, more older individuals. You can see these grayer bars are lower, which everything below the top of the gray bar is people under 30. So they're a little lower than they are in Bernalillo County. particularly for this part of the pandemic. So in general, I know we're all really searching, I know I am, for a specific reason that of something people are doing that we can tell them to stop doing. And at this point, we're not finding those common themes in the contact tracing interviews, so the case investigations. And so I wish I had more for you on that, but I don't. And here's some really interesting data. And I'm not exactly sure what it means just yet. We're having a lot of conversations about this, but this is just percentages. So we don't have to, so we correct for the variation in the number of cases. This says, what percent of cases have symptoms and don't have symptoms? The orange is no symptoms and the blue is symptoms. And this one isn't as obvious in the 29-year-old age group, but all these graphs are starting to show a downward trend. And if you were to squint and draw like a linear regression line, it would come right about here, it would be downhill. You can see in the 30 to 39-year-old age group, significant increase in the number of asymptomatic people up to 50%. This is those two groups combined, and again, kind of a decreasing number of symptomatic people when we get the positive test result. And I think this could be due to a number of things. One would be that we're seeing more. I think we're doing a good job with contact tracing, and so if we contact people and say, hey, you were exposed to a COVID positive individual before they have symptoms, and we isolate them and get them a test, we should see an increasing number of asymptomatic people. That's really success. I mean, in the end, the people who are symptomatic in general are going to get tested. The people who are asymptomatic are not. So this trend in upward trending asymptomatic cases, for me, is a good thing. I think it could also represent the fact that people are now more informed about COVID, thanks to all of you, and they're getting more information, and they're realizing, hey, maybe I ought to get tested as well. And so I think I'm taking it as a positive trend. Race and ethnicity data. You asked for more data about the 20 to 29-year-old group, and if someone wants to just raise their hand and cry uncle, when you've had enough, we can move to the next section. The race and ethnicity, very large plateau, peak and plateau in the Native American, Alaska Native population, and thankfully we're seeing that drop off in the younger age group. If you like squinting, this is a better way of seeing the distribution. Now we're seeing a big uptick, and this is really a story, I think, in the Latino population, who is running, less than you would expect. So the Latino population is as high as, in some counts, 40 to 42% of New Mexico population. And they were running at about half of that for case counts. And now they're getting back, then they got back to about their distribution in the population, and now they're above it. And so there's something going on there that we're trying to understand better, but we do, again, through contact tracing, don't have any specific identifiers that would tell us what is going on that would make this different than other race ethnicity groups. And then I've got the same two graphs for you for the 30 to 39-year-olds, and just that same plateau. When you add, the 30 to 39, very similar here. And again, that similar significant increase. So a very significant increase beyond what would have been expected just by percentage in the population of 20 to 39-year-old Hispanics acquiring COVID in the past month. We already talked about this, and I'm going to move on. Doña Anna, similar. The way I read these graphs, particularly in answer to all your questions about young people, I follow this gray bar line to see what it's doing, and it's trending up. People under 40 are under 30 are trending up, certainly. This is a little bit more choppy here. And this is, sort of illustrates what happens when you try to do this kind of data on small counties. It's all over the map. And I don't know if we can include anything here, but we can say from a static point of view, in this week in Lee County, which was where we started to see the beginning surge of cases, they actually had about the same number over time of 30 and under individuals, if you sort of average all these curves, I would say. You may disagree with my squint test interpretations, and I welcome that. And then lastly, death rates have decreased, thankfully. Every death, every loss of a New Mexican is a sad event, and we've seen this is by week, more than almost 10 a day for a couple weeks there, and then we're trailing back off. Although with the increasing number of hospitalizations, we're likely to see another uptick, and we're just hoping it's not proportional to the last uptick. And then lastly, as age increases, and you know this by heart, the case fatality rate continues to increase. Different age groupings here for different sets of reporting the DOH does, but again, we're not seeing any change. But a 1% mortality rate in people under 44 divided this, so it's this whole group is more than we'd like, anyone would like to see in any group. So that's the trend there. That's all the data. We're going to get to gating criteria and walk through a little bit more on that, and then we'll be done. But if we want to go back and revisit any of the issues, because we've given you a really detailed presentation today. When I say we, I'm the one talking, but there's a whole team of people that actually put this together on what's happening with the younger age group in New Mexico. And I'm looking for mobility data by age band, but age decile, but I don't think that exists. So I would bet though that if we did that study, we would find that the people in these younger age groups where the case counts are way up are traveling much more every day. So let's pause. Alex, does anybody put anything in the chat or anyone have anything?
Yeah, there's several questions, David, related to testing. So, so the 430,000 approximately tests, does that include Texas numbers? So for example, Texas residents who get tested in New Mexico, are those test results from non-New Mexico state residents, are those included in New Mexico's test numbers? And the question's from Joy Wing, and she brought up a good point because that could influence our state positivity rate for COVID-19 testing.
Right. If 100 Texans have a different test positivity rate than we do, that would influence it. I know for sure the Texas cases aren't in our counts, and I know for sure that Texans in New Mexico hospitals are in our counts. But this is the first time anyone's ever asked this question about test counts. Frankly, I don't know. I don't know if they're filtered by zip code or state of residence. I know we get a lot of lab tests back, reports back from a lot of hospitals. So we'll check on that one and get back to you.
Another question, David, from Scott Weiland. Are we closely tracking New Mexicans who test positive but are in other states?
Yes. Yeah, so it's the same thing I said earlier. Let's say we have a Texan in Ruidoso who's COVID positive. We immediately communicate with the Department of Health. We've had some challenges with case supervision and case contacting. You can imagine that dealing with 300 cases a day, doing case interviews and contact tracing is 3 times harder than when we had 100 cases a day. But other states, when they find our residents are positive, they notify us. We add them to our tracking system. And Dr. Smelser could address this much better than I, but will. I know that's the case.
And then from Mara Aguilar, she asked, this is related to schools, David, what would happen if someone gets infected out of school? How will that work? And would it be the same at childcare businesses?
So I knew we would get to our testing strategy at some point, and some of you may have read the article in the journal today, the op-ed or the editorial actually, which, I think really, really clearly and very well articulated the most important questions we're dealing with this week about testing. And so I'm going to turn your question into a bigger question, if that's okay, Maria, but I'll get back to schools. There's lots of testing we do. We try to test people who have the symptoms of COVID, and they should be our first priority because we can identify them if they're symptomatic. We can, well, whether they're symptomatic or not, we test them when they're symptomatic, we identify them, we isolate them, we call them back with their positive test result, and we identify their contacts and we quarantine them. And so highest priority is, and sick people in the hospital, they're in general, I think that symptomatic people are getting tests. And then there's an intermediate group that I want to talk about before I talk about people with no symptoms, and that's the high risk groups where there either is now or has been guidance for more testing. The best example for this, although there are many, are nursing homes, where we know that if the staff are likely in some way, at least in the past, have brought cases into nursing homes. And so rigorous or regular testing for them. And then also in this sort of middle category are high risk places for the most part. They're mainly locations. They're usually congregate settings, again, nursing homes again, but detention facilities, prisons, group homes for the developmentally disabled, CYFD homes for kids. And so those folks are in situations where homeless shelters would be another, where if one person does get a case, we know that the spread can be rapid and devastating. And so Secretary Kunkel has set up and invented, as she says, the rapid response, where we go in and test everybody in those situations. And then, however, where we're struggling right now is this gray area. Like if you have a business in 7 different buildings with 20 employees each in each building who never interact with each other, and one employee turns positive, then you're going to be fine testing that person's contacts in the building. And so we're weighing the pros and cons of that. And then finally, there are people who are asymptomatic and not at higher risk. And I think that was the point that was dealt with in the article in the journal today very well, I think. And the thing we're really struggling with right now, because we have to maintain this prioritization to make sure we identify, number one, the people who are really sick and are spreading the disease. Number two, the people who are most vulnerable. And how do we balance that testing strategy with, 8-hour waits at Balloon Fiesta, almost every night. I can testify, I'm back to seeing patients, and I drove back a couple Mondays ago down to the university, and the line from Balloon Fiesta was all the way out to the service drive, all the way past Blue Cross Blue Shield, and all the way up to Tramway. And so we're working with our private sector partners to see if there's a way to divide up these duties. I failed to mention in the middle group, a critical group of people who don't have symptoms, but who we test prior to any kind of significant surgery. It's called pre-op COVID testing. And the reason we do that is in major surgeries, there's been a report that there's a 20 to 30% mortality rate, death rate from surgery in COVID positive individuals. And so we enforce basically a pre-op testing strategy in the state, and that falls in the middle group. So we're just talking about who can do what, and can the private sector maybe specialize in more symptomatic testing, and DOH specialize in more surveillance and asymptomatic testing, and is there a way to have a more common registration system and way of doing this where people aren't waiting in their cars all night. And it was really, my only regret on the article this morning was that it came out when it did, because I think we're going to have the answers to all these questions next week. But it also, everything is iterative, and knowing that the public has these concerns and really wants us. And I would say, I read the article quickly, but kind of demands us to solve these problems. It's really helpful, actually, to getting us to conclusions that I think will work better. So I haven't given you anything actually specific that's going to happen, because we're still deep in the process, much like school reopening. But I wanted to share with you some of the conversation and some of the mental construct for this. The last thing I didn't mention, I know this is the longest answer ever, is that something very significant happened a couple weeks ago when the federal government said insurance companies should not be paying for asymptomatic testing. Medicare will not pay for asymptomatic testing. Now, the insurance commissioner, the superintendent of insurance, Russell Toll, and I, together help manage about 70% of the insured New Mexicans. And we do have the ability through Medicaid and through private insurance to make sure that even people who are asymptomatic, who need testing, close contacts of individuals, everyone in New Mexico believes if you're a contact of a case, you should be tested. Insurance should pay for that. And I think in the federal guidance, they've issued additional guidance, which generally means here's some more information about things we didn't think of when we issued the original guidance. But they did kind of clarify and give room for case contacts. But so we're sorting through all that. But that's an equal pressure on the whole testing system, because it costs, I've seen estimates of $90 to $120 for testing for a test, between getting the sample, getting it to the lab, running the specimen, reporting the results out, and calling the patients with the results. And so that's a lot of money, and that adds up very quickly if there's no insurance coverage for the testing. Anything else on any other questions, Alex, or follow-ups on that? Because this is an important topic.
Yeah, so related to school reopening from Joy Wang, do you recommend school staff take kids' temperatures upon entry? Do you have any other recommendation about how schools handle kids that show symptoms? Go ahead, David.
There is a document that I believe is online called the Plan for School Reopening that came out. Much of what you're describing is in there, and the fine, that I think it's been circulated among the superintendents. So we've gotten a lot of feedback. So I think it's online. It will be very soon. But again, we're going to reach a decision about that. For example, with healthcare workers, in order for them not to have to 14-day quarantine, so we can keep the healthcare system open, we do have ways of taking temperatures, for example, for people who come in from out of state. We have, for example, surgeons who fly in to do operations in rural areas, and there are PPE guidance, temperatures twice a day, et cetera. So that's all going to be coming out soon, Joy, and you'll be able to see it in its entirety.
And then, David, on a different topic, a question from Algernon Damasa. Do you have any updated information about PPE supplies statewide and whether facilities are making use of decontamination reuse technology? The answer to that second question, David, is on slide 51.
Yeah, I figured. Although I don't know why, Alex, but I only have 50 slides in my presentation. So presentation, I don't see it, but I do. I've got information. So this is one thing that the MAT and the Department Operations Center are all over, is PPE and recycling of PPE. You guys must think I look at a million data points a day, because I'm always saying every day I see a report of, and here's another one, of how much PPE we've decontaminated. We went during the beginning of the pandemic, there was a massive supply chain disruption for PPE. Most of our hospitals, and particularly all the larger hospitals, had established supply chain relationships for PPE, but they were getting thin on PPE in March and early April, even with their big suppliers. But now that hospital volumes have dropped, DOH is moving more toward having the hospitals supply their own PPE, and other medical and dental and other providers work out their own supplier relationships, and have DOH's primary role be to calculate and then store up the amount of PPE we'll need for the next supply chain disruption. And so I know the governor charged General Nava and our new Department of Emergency Management Secretary to really develop a detailed plan. That's in the works. We're good on PPE supply. We have that in the gating criteria. I'll show you that. And through the press conferences and you getting the word out, we're seeing a continuous stream of uptake of people who were not using the N95 mask decontamination facility in Rio Rancho. There's an uptake and more people are using that. We even keep track of how many masks get rejected. I think it's 5.9% yesterday. And the number one reason they get rejected, which is 90% of that 5.9%, is people wearing makeup to work and wearing the mask over it. And you can't recycle masks that have rust on them, that have makeup on them, and or that are, I forget what the third thing is, but it's makeup and rust, I know are two of them. So
No
we'll
valves, no,
I think, what'd you say, Alex?
no valves. So
Yeah,
the mask cannot have a valve.
Yeah, we can't recycle masks with valves, and we don't really recommend, like, a mask with a valve is better than no mask at all, but we prefer people buy masks that don't have valves in them for their personal use. Well, let's go through the gating criteria. Not pretty. Alex, though, whose glass is half full, as is mine actually, has highlighted the three in green that are meeting the target. Sometimes we highlight in red the ones that aren't. And I'm gonna talk about spread rate in a minute near the end, because spread rate turns out not to be working as well for us as we hoped it would right now. But testing capacity through the roof, you can go on and see, but just record number of 7-day rolling average tests here in New Mexico, third highest in America on a population basis. Amazing work being done, and now with because we want to do the best and be the most efficient we can in testing, we're looking at that process and figuring out how to better prioritize to ensure people with symptoms are guaranteed they get a test. Contact tracing, no big surprise here. We like to see these case interview done by 24 hours, and we've doubled that. We'd like to see our case contacts at 36, and that's more than double. I know I may have mentioned this last week, but it takes about 6 weeks to hire people, and so we're just a little behind the curve on this. There are new people in the hiring process. Being a case interviewer is a much more sophisticated job than a tracing contacts, and so there's extra training for that. So we anticipate catching up, but it's a hill now that we have to climb. Hospital beds, good. I already warned you that the bed counts are going up, but we'll watch that closely. And then rate of spread, which has been our mainstay forever, is, if you look at the case curve, you'd say, oh my gosh, this is the worst it's ever been. And you look at rate of spread and we're at 109. So the modeling team recommended that we add a growth rate measure to this as well. And one of the things we're learning is some measures work better on the way up the curve than they do on the way down, and vice versa. And there's some theories, but we think the formula, which is very complicated for rate of spread, doesn't do well if it has to cover a period of both decrease and increase in cases, if that makes any sense. If you have two trends in opposite directions, the formula seems to become a little unstable. We think that's what's happening. Nonetheless, it's not bad. Let me go to the next slide though. And, this is, so good news for New Mexico. We're still red. The bad news is we're still red, but the good news is they have something even worse than red now, and we're not it. They call it bruised red. So this is, I guess, the equivalent of like, don't even get me started how bad it is in our state. But you can see that we're surrounded on to the east and west by states, which you know from reading the news, have much, much worse case counts and much greater accelerations. And we do, not to minimize ours. And so and this may get to an earlier question as well, but our 14-day trend of COVID is increasing 39%. So in other words, our 14-day trend, I think 14 days ago is compared to today, today's count is 39% higher. You can see those numbers here and do the math yourself if you like. Influenza-like illness, we don't have much of. They've actually, to help us, I think, they used to just say if you met your test target, and now look at this, New Mexico is doing twice as many tests as the 500,000 tests per day in America guideline would predict we should do. ICU occupied, there's a story here. If you want to ask a question about it, I'll talk about it, but this is due to the disruption of data being sent to the CDC for a temporary period of time. And then new cases were red here too. So positivity rate, we're good. I've already showed you that graph. We're doing great there. Hospital beds, just one more time since they're going up. I pulled this data. This was a question maybe last week or someone asked me during the week. How many beds does America have per 1,000 people? Is 2.4 beds. There's 2.4 beds for every 1,000 Americans, 4.8 for every 1,000 people who live in South Dakota. Number one, Oregon, worst at Oregon at 1.6. And then New Mexico here near the very bottom of the pack at 1.8. Arizona, no help on the other side of the border, high as well. And so the reason we worry about this when we see cases go up and when we model it is, it looks like we could have, less than 60 days if case counts continue to go up. So let me orient you here. Blue is bed capacity and what our limit is, which is even off the chart, so you can read this better. Red is ventilator capacity here, and what our capacity is here and what our ventilator use rates will be through the modeling. And orange is ICU. And what you don't want is the same color lines to cross. And you can see here that we're getting some predictions that if everything keeps going as badly as it's going and the cases keep going up, that we will completely strain our resources. Now, astute people among you will notice that might say, hey, I thought this was 460. Wasn't this 460? And it is. But what we're doing now is adjusting the line to look at to adjust to the number of open beds we currently have, which is about 170 right now. And so this is not good news. We're very focused on this. Mask wearing could help decrease this. Decreasing mobility could help decrease it. And hopefully some of the changes that have been made could help. And then Alex mentioned these slides, and I've been bragging about what I look at every day, but we do follow we follow the southern region, the northern region, and the central region because the southern region and northern transfer to central. A lot of transfers to, of course, to Phoenix. So just very quickly, northern Arizona with limited excess bed. These are surge beds. So the governor ordered them to increase their ICU capacity by 50%, and I think they just added the numbers up, but surge beds here, very, very long, identical number of beds, which makes one suspect about the data. And then this, by the way, is southern Arizona on our border, and then central, that has a lot more beds. And for some reason, they miraculously came up with another 200 today. Now, there's another website you can go to in Arizona and look at a dashboard that has even more data. We've been keeping these slides. We may switch to just using their dashboard, but we can get the data current to the current day. And the dashboard currently seems to be delayed by 2 or 3 days. So we're still using our own data right now. We also have regular conversations with the folks in Arizona as well. This is med surge beds, so regular hospital beds. Plenty of beds available throughout the state of Arizona right now. Texas,
Hey,
we
David.
also, yeah.
Hey, David, I hate to interrupt, but it's after 1 o'clock and you've got another appointment, and I want to.
Oh my gosh.
Yeah.
Oh my gosh, I am sorry. You know, I might be a little late. It's up. So we watch those two. Substantial bed capacity in border areas. This being El Paso with 400 extra overflow beds. They don't keep the ICU separate. So just a reminder, public health order, only Mexicans should be staying in their homes for the most essential, except for the most essential activities and services. To make it simple and to keep it simple, we've asked everyone to wear a mask when they're outside, even when you're exercising. Only exception to mask wearing is eating and drinking, and I think swimming would apparently be an exception too. We've pulled back on indoor seating. Just again, other jurisdictions, counties, and states have done this and believe it's effective. But still outdoor seating in restaurants, and then no more access to out-of-state residents for state parks. I think, as the governor puts it, we want you here in New Mexico, but maybe next year. So, and all the COVID safe practices for businesses are available online. Oh, I do see the slide now. I don't know what was going on. This is the answer to the question about Battelle. We're almost up to 15,000. More and more facilities. Encourage people you talk to. And here's the slide. Makeup, fire reject, can't do rust, can't do valves. It was there, thank you. Medical Reserve Corps volunteers, shout out to them. Hundreds and hundreds of hours, almost 20,000 now. And we get a lot of calls from people who say, hey, I'm retired, I'd like to help. And there are actual safe, really helpful roles for older people that don't involve contact with patients or sick people. So we're still recruiting, we're always recruiting. And I think I've got a healthcare line, a support line. I think we're done. So let me take another question or two, and I will have to get off after that. But who else would like to ask something?
Yeah, David, I'm going to unmute Gabrielle Burkhart, so that she can answer her question. She has been patiently waiting. Gabrielle, you should be able to ask your question.
Okay, yes. So I was just curious, Dr. Scrase, if you are learning or if the Department of Health is learning any more about antibodies. I know you sort of touched on it a little bit in the beginning, and I know that the CDC and Dr. Fauci have addressed maybe how much of the population, maybe 10 times as much, have maybe already had this virus, didn't know it. Are you learning anything as far as that goes? Our antibody testing, could there be any use for them?
Yeah, we have 3 papers. The MAT has 3 papers on the website about antibody testing. It's really complicated. A couple things you need to know. Number one is that many, I can't say an exact percentage, of the antibody tests on the market are not necessarily reliable. Like they might give you the correct answer, 70% of the time or 60% of the time. So that's a problem. We're still recommending only using hospital labs or reference labs like Tricor and the state lab to run that testing. And then the next thing is on antibody testing. We do have a way of calculating, what we call it a multiplier. And it's for every one person with proven COVID, test positive COVID, how many people are there out there that also probably have COVID? And I don't want to go into great detail, but we do it. We use it. It's a proportion of the number of actual deaths that we've had divided into our expected deaths based on the medical literature and established death rates. So that's what we're using right now. We're kind of at a 5-to-1 ratio. Originally, there was some crazy data that came out that suggested that, for every one person, there was, 80 or 50. And I think now, as we're rolling that back, the statisticians are waving red flags about that. But the number I use in my head is 5-to-1. I think it's more, but I don't think it's 50-to-1.
Okay, David, for the final question, I'm going to turn it back to Mac Grubbs, who submitted a question in the chat that I'll allow him to ask you himself.
Hi, David. So I was speaking with someone this week who said, look, it's not as bad as you think it is with respect to COVID-19 because we've got a lower or a stable morbidity rate. And yeah, we're getting more positive tests, but morbidity rate is really what you want to look at to gauge whether or not we have a bad situation and or effective response. How do you weigh that? Where does that fit in with you?
Probably I'm like somewhere in the middle between this is the worst thing that ever happened to humanity and that perspective. I do think that I'm a physician, so I'm going to have a very strong bias that I'm probably not going to be able to control. But when you do see a decrease in death rates, that is very, very good. And I showed that curve where it was sort of a bell curve. It went way up, and now we're quite a ways back down. It's sort of another way of getting at the same thing as I sometimes say, maybe we just don't need modeling. Maybe we just wait and see how many people show up in intensive care units, and that's how we know how we're doing. The trouble with that is you don't have any advance notice for that, and you're overtaken immediately. So modeling moves us back 3 to 4 weeks to anticipate those things. But I don't disagree. If you look at hospitalizations or look at ICU stays or ventilator use or unfortunately deaths, I do think those are all better measures of the burden of disease in the state. And so, but I guess and the last thing I want to say about that on the mortality rate, we're like 3 weeks, so I said this earlier, cases go up first, 2 weeks later, hospitalizations go up, and they are. 2 weeks after that, deaths start going back up. So I think I think what that person said to you yesterday was a really valuable observation for 4 weeks ago, but we now have to see what happens with this lag and see what we determine. The fact that death rates are down in older people is really good news, particularly over 80, a little bit, maybe the same or a little higher in 70 to 80. And the fact, of course, that there's minimal deaths in younger people is encouraging as well. And if we are seeing a surge in cases and it is more young people, then my hope would be, and those young people have less complications, then my hope would be that we'd see I can't come up with a number, but maybe only 2/3 of the hospitalizations and maybe even less than expected ventilator use and hopefully less deaths. So I think looking at how we're doing based on the ultimate consequences is fine. It just gives you no opportunity whatsoever to prepare for what's going to happen in a month. So I think I like that answer the best. So use that one. Okay, Matt, thanks.
Okay, I will. Thanks.
Yeah, I really appreciate it. I was just going to say, I appreciate you all so much. You're getting the word out, and I'm really serious. Getting the word out is good. We all take criticism. We all get complimented. It's part of the work. And I'm actually appreciative that we're getting some state focus. We were already doing it anyway, but getting the focus on what is the testing strategy. I think the governor really wants to strongly encourage, and you can quote me quoting her, strongly encourage anybody with symptomatics, and anybody who has come into contact with a case, and anybody who's really high risk, in a high risk situation, the sort of highest and mid priority groups, we really want to push that. She really wants to push that. And I think that's more of the message that you're going to be hearing next week when we further define this. So that's I hope you hear that as a little bit of a change in emphasis. It does address 1 or 2 or 3 paragraphs in the editorial this morning, and it's where we are today, and we'll be a little bit further along with that and have more for you next week, hopefully by the press conference time. With that, I'm going to say goodbye. I do have a obligation, a legal obligation I have to meet. It's not news, but I got to get to that as part of my role as the Secretary of Human Services Department, and I will look forward to interacting with you all. And send those questions to me. If you really want to get answers to your questions, send the questions to Alex and myself. If you want to just eventually get an answer, you can send any additional questions to me, and we'll work to get back to you, or we will work to weave those answers into future press conferences, like actually, frankly, we spent most of our time doing today. So thanks, have a good day, wear the mask, and for gosh sakes, please remember it needs to cover your nose and your mouth and your chin, and be tight on the sides. Signing off, have a great day. Thank you very much.
Thank you everyone for joining today. We'll send a copy of this presentation as well as the link to this webinar recording to everyone who registered. Thanks and have a good day. Bye-bye.